So I'm going to go through this really quick. So the purpose of this session today is to give an introduction to service design specifically for community-based health innovation. So there's a lot of words in there, a lot of concepts, and we're not going to assume that anybody already knows about any of these things. So we'll be spending time talking about all of this. So a quick outline for my brief 5-minute session here. I'll introduce our team, give a quick overview of why this session, outline the agenda, and then just a couple notes on process. So here's our team. I'm Jay Sean, a research scientist at Women's College Hospital and research director of AI ethics and health at the Joint Center for Bioethics at U of T. We have Paolo Korre, who's a service designer, has lots of experience working in service design in healthcare. He'll be giving our overview of service design today. Dara Gordon is a PhD student at University of Toronto and research coordinator at Women's College Hospital. Joseph Donia, PhD student also at U of T and a research assistant at Women's College Hospital, and also founder of a design firm Huddle. Zayna Khayat, future strategist with SE Health, and Alexis Wise, founder of This Is Consulting Services and an SE Health Housing for Health fellow. So this is who we are. You'll hear from all of us today, and some of you will get to see various members of this team during the breakout sessions. Okay, so why this session? Why is this a part of the series, and why are we interested in this as presenters and facilitators for today? So in various domains, we have all been working to bring innovations to life with a particular emphasis on where people live, their homes, home and community care, thinking more deeply about the continuum of care going between places where care is provided. Some of that, a lot of that has involved digital technology. So we've been working at this, collectively for a number of years. Now, we, notwithstanding our best efforts, certainly have seen this effort to innovate crushed by the ivory tower. And when I say ivory tower here, I'm referring to big institutions like healthcare or medicine, the expectations of governments, and also, honestly, the expectations of universities. And what tends to be crushed in our experience is this acknowledgement of the messiness and the iteration that's required in the early stages of the innovation process. So this, perhaps many of you have seen this image. It outlines what this messiness sort of looks like at the early phases of discovery and design. And that moves into, of course, delivery. And that linear, clean, simple process of delivery is what the ivory tower tends to expect. So we're here talking about this messy part, how to sort through that, how to work through that, what that is in order to get to this cleaner expectation of what we imagine delivery to be. Now, another important motivation is that this work, community-based health innovation and service design, can help to advance a social justice agenda. So there's this approach called design justice. I won't be saying anything about that now. We'll hear from Joseph a little bit about that later, and from Dara a bit further about how these kinds of innovation initiatives can acknowledge and support a social justice agenda. So for the outline of what we'll be doing today, immediately after I finish here, I'll pass it off to Zayna and Alexis. They'll give us about 10 minutes on what is health innovation, how can and should we be understanding that concept. Then we'll move on to another 10 minutes on social justice and health innovation from Dara and Joseph. Then we'll move on to Paolo, and he'll give us the sort of meaty overview of what is service design, a basic introduction to the concepts of service design. So as Alex already said in the introduction, we'll be monitoring the chat function for questions. And at that time, we'll take stock to see, are there some important questions we want to address before we move into the breakout sessions? Then at that time, Paolo will introduce the activity we have planned. We will be using a program called Jamboards, Google Jamboards. So we'll give an overview of that. We'll move over into doing our breakout session then. Then we'll all come back together just for another 10 minutes or so for some kind of concluding thoughts around what we've learned in the session. So, I've already mentioned about comments in the chat. When we do the breakout sessions, we'll have roaming facilitators. So Paolo will present an overview of the case and the kinds of things we're asking everyone to do in the breakout sessions. And we would ask that when you get into the breakout sessions, you spark up some discussion with the people in the breakout room. You'll all be given a link to the Jamboard, so you can open that up. It outlines the case scenario that we'll be talking about today. So you can spend some time reading that and then dig into the activity that we'll outline shortly. I mentioned we'll take that up afterwards, and then feel free to reach out to any of us after the session, and we have our email addresses listed on the final slide. So I'm going to stop sharing here, and I'm going to pass it over to Zayna and Alexis.
Thanks, Jay. Thanks for the introduction. Hello, everyone. Really nice to see some familiar faces. I cannot share just yet. Oh, there we go. It's open. So really important that we start with a common language and understanding of this word innovation. And then, so I'll do that. And then Alexis, my colleague, will talk about the community spin on it. I think that'll set us up really nicely for the thesis of this session. These Bitmojis is the real me and Alexis, unlike those earlier studio photographs. So this is my natural hair color. And I think Alexis and I will agree that hair elastics is the new industry you need to invest in. Thank you, COVID. Okay, so first is like this word innovation. It's used a lot and sometimes in healthcare used to really describe anything. So let's first understand where it came from. So did you know we can thank lawyers for the word? So back in 13th century law, when things were starting to be invented really that were quite new and different. So to come up with a word to allow law to protect inventions, they said this is nova. It's new. It's so different from anything we've had before. And then the word really evolved into novation. And then, of course, now we say innovation. I don't know where that happened. Textbook definition, actually probably the best, simplest definition came from the Canadian Council of Academies. New or better ways to do valued things. Two most important words, new and value. Value means something has been created that's measurable as a result of the new. And I think we use the light bulb, right, as this universal thing. And I kind of get this gut-wrenching thing because we obsess with the metaphor that it's about this aha moment where the light bulb goes off. And that is like just the start. Yet, we're obsessed. So when Alexis and myself used to work at Mars, and Alexis and I worked on how do we actually get the value in the health system from all the innovation, our algebra was innovation is the sum of invention, so coming up with the new, plus adoption. And adoption is at scale, really important. I teach a course this semester on health innovation. Some of my students are on this. And so we put up a case study of the COVID app. Does that count as an innovation? When, I think in Alberta, very, very few of the population, and across Canada, 5 million have adopted it, but has value been created? So really important. And I would say these human-centered design skills we're going to learn help you do invention very well, but actually set you up so that adoption happens. Okay, so that's the basic. There are many other textbook definitions that you can use for different purposes. The one we use in my course, where the core textbook is Clay Christensen's really Bible for innovation in healthcare, called The Innovator's Prescription. You can get a lot more specific about, what is involved in innovation, and it just helps emancipate you from, a very narrow view that there's some kind of a product like a light bulb, or that it's just about one care pathway or like one single point. And as we're going to talk about, having a broader understanding of ultimately that innovation is something new that adds value helps you tackle community health innovation very differently. So other ways to kind of just talk about what innovation is and it isn't, we often interchange thinking innovatively with doing innovation, and they're not the same. Creativity is using your imagination to come up with those, better ways of doing things, but you're only innovating when you convert that to impact. The other one, like I talked about, invention or technology or, a policy innovation or social innovation. You can use creativity to come up with those things. That's the invention, but you've innovated when you leverage that to generate impact. And then this was my probably favorite definition from our colleagues who lead the innovation team at Kaiser Permanente in the US, where they really needed to keep separating their innovation work from improvement. And improvement is the dominant tool, as it should be, in healthcare for making things better. That when you're doing innovation, your intention from the beginning is not to improve, because improvement implies the thing you are already doing is pretty good. It could be better on outcomes or something like that. The intention for innovation is a massive lift, and with my innovation team, we're looking for 5x better than the status quo. That's your lift. That's your pink stuff. But when you're done, the first time you roll that out, it's your worst best place. The first version of the iPhone is nothing like iPhone 12. So improvement is then what then takes it and makes it better and better. And that's why I have a huge problem with the language incremental innovation, because it implies that the job to be done is just to incrementally improve, and you just slap the word innovation on top. And in my view, the problems and the jobs left to be done in healthcare require a methodology and approach for a massive lift. So kind of putting it all together, our work as innovators in healthcare is to take the status quo and really get that 5x lift, which is how different is this new thing from the status quo. In healthcare terms, that's the standard of care. How different is it? What is it going to displace that used to be done, and often used to be done for 100 years in healthcare? And then the horizontal is how much did you implement at scale? And that scale is usually like 30%. That's all you need. You don't need to be 100%. And so, creativity, improvement, we can map. You're in the northeast corner if you're doing innovation. So I'll kind of hand it over to Alexis to now take that and apply that lens to community health.
Perfect. Thanks, Zayna. So I love that the topic today is all around community health, because I think the scope for innovation in this particular space is immense. And not only is the opportunity huge, the urgency right now, more than ever, I think, is so enormous. And so you take a step back and look at what's happening in health systems really around the world, you're seeing this massive reframing, right? And this innovative approach, trying to innovate, is also really reframing. So health systems everywhere are thinking about what they do, where they're doing it, and who they are responsible for, or who they're doing it for and with. And so this community health question today really lives in this incredible in-between space that allows so much flexibility to answer those questions in new ways, right? What are you doing? What's in and out of scope for community health? Where are you doing it? And who are you responsible for? And who are you working with? This shift is really important in thinking about what is in and out of scope. So the shift really is to take what we are traditionally spending our money on, spending our resources on in the medical care, in medicine, and expanding that definition to adopt a much broader definition of health that finds importance in all kinds of things that happen outside of medical care. It also really is, we talk so much about patient-centered care and the important needs of the individual, and that is vital. But it's also broadening our understanding of what it means to be healthy and thinking beyond singular individuals and thinking about communities. And communities might be a geography, communities might be a family unit. There's lots of ways to think about community, but adopting a broader definition of health is really key for this work. Go to the next slide, Zayna. So this really just maps kind of what I've said, narrow focus when we think about what the opportunities are if we just think about medicine. A slightly broader focus if we're using the definition of healthcare and what's within the scope of healthcare. But if our goal is really to improve long-term health outcomes for people and for communities at large, we have to adopt this really broad definition of health, which often necessitates us bringing in all kinds of unusual players into the conversation and really sort of challenging our own limits and definition of what it takes to get there. Next slide, please. For the work that we're doing today, and you will see this repeated, I think, several times through the presentation, I really want to emphasize that if we're taking a service design approach, this definition of health is also important from an individual's perspective, a patient's perspective, a customer's perspective. That experience of day-to-day health needs to be at the forefront of our thinking. And any individual's interaction with the healthcare system is really limited to a small number of hours in their week or in their year or in their life. They are responsible for maintaining their own health for all of the remainder of the hours. And it's how we support those individuals to do that best, really, where I think there's so much room for us to discuss sort of innovation today. But it's going to be really messy. And so we have to spend time in that messy place up front. There's going to be things we try that are failures. We're going to try things that sort of have some traction and can build. And we just don't know what those are going to be until we roll our sleeves up and get working. And so I love this because you have a ton of uncertainty in this first part where we're spending our time today, and it's supposed to be that way. So if it feels a little bit uncomfortable, you're doing it right.
Yeah. Great, Alexis. Yeah,
Anything
I often
else?
say that in this work, the problem you're trying to solve, you actually can't understand it until you start solving it. And that's a bit of what the messiness is. So hopefully that sets the stage. We good, Jay?
Perfect. Thank you, Zayna and Alexis. And if you guys can stop share, then we'll pass it over to Dara to introduce us to some of the ideas of health equity and social justice.
Thank you. I think Joseph is just going to share the slides for us. Awesome, thank you. So as mentioned, my name is Dara, and Jay's asked me to share a few insights about incorporating equity into healthcare innovation. Oh, actually, if you can go back a sec, Joseph, that would be great. Cool, thank you. That's also my Bitmoji. She doesn't really have bangs in the way that I do. I couldn't figure out how to make that, but anyways, we could talk about hair all day. Before discussing these insights about incorporating equity into healthcare innovation and service design, I wanted to take a moment to introduce myself as someone who has intersecting identities as a first and second generation settler with roots from Germany, England, and Poland. I'm Jewish, I use she, her pronouns, and I have an autoimmune disease. I'm also someone who is in solidarity with structurally marginalized communities and is committed to dismantling systems of oppression. I think it's important to share these details about myself because they show a little bit about the layers of my identity that make up who I am, how I move through the world and how I experience it. Realities that are actually crucial to good service design, because how I experience the world based on these identities is fundamentally different than how someone else might experience the world with different identities. And so it's important for us as service designers to think about and to have the humility to recognize where we might have blind spots when designing innovations based on our own identities and likely privileges. I also share these details because the insights that I'm going to share or discuss have been generated by a collective of folks called the Women's College Hospital COVID-19 Equity Advisory Group. And we're a group of Women's College staff working to advance equity in the hospital in the times of COVID, including making recommendations to the team running the assessment center, the vaccine working group, the virtual care team, and many other departments across the hospital. We're led by Black and Indigenous colleagues, Dr. Aisha Lofters and Dr. Lisa Richardson, and work in collaboration with a few other folks from across the hospital. And collectively, we're trying to make sure that we don't overlook any blind spots for any populations when it comes to COVID. So I share these thoughts today as a representative of that group. I should also note that the insights that I'm going to share are actually more program development oriented, but I think they still closely relate to the goals of this session in service design. And I think Joseph's comments will help bring them even closer together. So let's go on to the first one. The first is that if you overlook the needs of equity-seeking groups and intersecting identities, the service design work that you're trying to do will be pointless, kind of, because you'll be missing huge swaths of the population. And this work can't happen after the fact either. Lots of times people think that they're not overlooking the needs of equity-seeking groups, and then they realize that they have, and the equity work happens after the main work is done as an add-on. And that doesn't really work. So for example, with regards to the Women's College COVID Assessment Center, we've thought through the experiences of different equity-seeking groups before their arrival, so including their registration for their COVID test, how does the website appear to them, how do they interact with it, their experience while they're at the assessment center, and then their experience after they've left, specifically related to how they get their test results. Because again, that's going to be different for different populations. I'll go on to the next insight. And this one is related to community engagement. So I'm sure, as you all know, community engagement is a must for service design, but it has to go beyond kind of the usual suspects. So able-bodied, English-speaking, housed, cis, heterosexual, white participants with OHIP cards. And thoughtful engagement will take time, and it's rooted in relationship building. But don't rush the process. Find ways to build relationships with community members and community-based organizations. And this process will work towards making sure that your design is culturally safe, trans-inclusive, gender-affirming, and hopefully even trauma-informed. I know it's in our funding environments, it can be really challenging to try and make time to do that engagement work meaningfully. But it is possible. A few of us on this call have a colleague at Women's College who has a 3-year grant and has spent the first 6 months of it just building relationships with patients. So it is possible. And the last insight that I'm going to share is related to data collection. If socio-demographic data or social determinants of health data is being collected for any part of your service design research or approach, ask yourself why you're collecting the data and where it's going to end up. Is it to identify disparities in care? Because that would be great. But you'll need to have a plan for how the data is going to be used. For example, how to track the progress in eliminating disparities. That keeps the accountability going. And any data collection, management, analysis, reporting, or knowledge translation related to Black and Indigenous groups must be led by these communities and should be informed by standards such as the First Nations OCAP principles of data collection, which stand for ownership, control, access, and possession, as well as the Government of Canada's Tri-Council policy statement on ethical conduct for research involving humans. So there's ways to make sure that data collection can be done safely to be supportive of those communities. And that's it for me. Thanks so much.
Okay, thank you, Dara. I'm just going to pull up my slides. Okay. As Dara mentioned, I'll just be briefly introducing design justice, which is just one approach to design that sort of explicitly engages with these questions of equity and social justice. And it's by no means the only approach of that kind, but it is an increasingly popular one, probably because of its more community-driven approach to innovation. And my own interest in this work really comes through my engagement both as a graduate student and as a designer with these questions of ethics, values, and public involvement in technology design. But I think these insights are really sort of broadly applicable from services and systems to the built environment. And I should just note as well that, you know, these ideas are not my own. As you can see, they're the result of a years-long collaboration process. And so I'm just grateful to have the opportunity to platform some of the ideas that I'll be presenting to you today. So as a bit of background, design justice came out of a conference workshop in 2015 that was led by Sasha Costanza-Chock, who's an MIT media scholar. And the focus of that workshop was this question of how design can move beyond good intentions to more explicit engagement with issues of social justice and equity. And so to these design practitioners, it was clear that those who often were most adversely affected by design often were those who had the least say in design. And so to them, this involved sort of, or required a reconceptualization of the design process and its priorities. And so to do so, it draws on a number of theoretical perspectives. For example, Patricia Hill Collins's Matrix of Domination, to question how design is implicated sort of centrally in sustaining white supremacy, heteropatriarchy, capitalism, and settler colonialism. And so it includes these fundamental questions of values, like what we're designing for, scope, how we frame design problems, sites, where we design, ownership, who controls design, and then of course equity, which sort of encompasses all of these questions, but really drills down into who ultimately benefits from design and how. And so as a field of theory and practice, it really privileges equitable distribution of design benefits and burdens, fair and meaningful participation in design decisions, and recognition of these community-based traditions, knowledge, and practices. And here you'll see 4 of the 10 design justice principles that were developed by the Design Justice Network. And of course, we don't have time for all 10, but I'll just give a quick overview to 3 in particular that I think are really illustrative of its broader agenda. So central to this first principle is grappling with the tension that structural problems can't always easily be designed away. And being attuned to these root problems is essential to challenging oppressive services and systems. So design justice focuses on what's needed in the immediate term to sustain, heal, or empower a community, while recognizing that the work to be done is often longer term in scope. And similarly, this involves a recognition that the problem at hand might be further upstream than we initially think. So in acknowledging these upstream influences on design, we can keep solutions focused on real community needs, as opposed to challenges that are most quickly identified or most easily solved. And eventually, bit by bit, the idea behind design justice is that these changes at key leverage points in short and medium term projects can help to contribute to longer term sustainable change. And so design justice is also concerned with what a community actually gets out of a design process. So for example, Costanza Chalk suggests this might mean rethinking what the move fast and break things ethos of innovation actually means for those impacted by design experimentation. It doesn't mean doing away with experimentation and adaptive learning, which is really central to innovation, but rather that designers and researchers should, 1, always consider the unintended consequences from testing an idea in the real world, and 2, that these can often be best anticipated by early problem definition and prototyping in close partnership with community leaders or community organizations with really deep knowledge of the problem at hand. I know there's a bit of jargon in there, but Paolo will introduce you to these concepts shortly. And then the third one is that design justice recognizes that sometimes solutions to problems already exist in the community or involve alternative ways of knowing and doing. And so practically, this might mean shifting the role of the designer from one of leader or expert to equal partner, whose job it is to mobilize resources and amplify or retool existing solutions to make them more impactful. Design justice recognizes that no design sites or utopias, all bring their own challenges related to power dynamics and resources. But I would say that this is definitely true of any design project, whether a design justice approach is taken or not. And so there are a number of things that design justice really makes us pay attention to, I think, when engaging in community-driven innovation. One is that it might require new knowledge and skills that are outside of our comfort zones. It might mean explicitly addressing and sharing power. It demands a rethinking of assumptions about what the problems and solutions are. And it means recognizing that the biggest changes probably involve a longer time horizon. And I don't think this has to, make a perfect community partnership an enemy of the good, but rather it means taking time to sort of reflect on how established ways of doing things might not always work in the way we think they will, and then using that as a sort of basis for charting a meaningful path forward. And so here are some resources that I found helpful in my journey through design justice, which continues. You can actually access the Design Justice book. It's open access at designjustice.pub.org, or you can join your local chapter of the Design Justice Network. I know there's one in Toronto, but I believe there are 12 now in various cities and regions all over the world. And with that, I'll turn it over to Paolo.
Awesome. Thanks, Joseph. Paolo, why don't you go ahead and load your slides? And I'll just say we're only sort of a couple minutes behind our scheduled timing here, so I think we're in really good shape. So over to you, Paolo.
I want to make sure I'm sharing the right screen here. All right. Are you guys seeing my regular slides, or are you seeing my presenter view?
Regular slides with nice fonts.
Oh, beautiful. Thanks for pointing that out, Jay. I love how you pay attention to those details. For many of you, this talk is going, I see some my friends from Alberta Health, hey, Marlies and friends and Brianna, and this is probably old hat, and this will be really familiar, but for many of you, my talk isn't intended to necessarily introduce you to design. It is to disavow you of some old held beliefs about what design is, and who a designer is and their role, and reframe that a little bit so that it is useful in your context, in public health context, and in designing and working with people more broadly. So the term design tends to carry a fair bit of baggage. Many people think, oh, beautiful fonts, or a well-appointed interior with complementary accents, the well thought through graphics that communicate just at the right time and compel action, and probably even more, that creative inspired lone genius who through their own wacky ways comes up with brilliant products or brilliant things that will sell. Not that I have anything against Kareem Rashid. He's a very, very talented designer who's has been very successful designing and marketing and selling really colorful objects. But that's a little different the way I'm thinking about it. Design at the core of all of these carries the central value or central focus is on the individual and their act of creativity. These are creative people doing creative things through their creative whims to create these beautiful things. But what does that have to do with tackling something like obesity? This is a map of someone did a great job visualizing the interrelation of the challenge of tackling obesity. This is what's known as a wicked or complex problem. There's no start, there's no ending point. When you act on one part of the system, it changes the other part. And the only way you can really understand what the map is to actually get in and start trying to tackle it, only to realize you don't fully understand the nature of the problem. One of my mentors, the founder of a design firm called Doblin, which was bought by Deloitte, a fellow who was named one of the 10 most influential innovation thinkers in the world, Larry Keeley, had this to say about creativity. In the face of complex problems, when you feel the urge to be creative, lie down until the feeling passes. So that's a little strange for someone talking about design, and design that tends to be all about creativity, to say, lie down until the feeling passes. I think Larry was intending to be provocative because of the overemphasis on creativity, when it is in fact only one small part of a healthy design process. I want to propose another definition of design that might be new to many of you, and it was from a social scientist, Herbert Simon, and it feels a little more appropriate, a little more accurate. Is design is the process of going from an existing condition to a preferred one. And in there is, to do so, there is creativity, the nature of creating new. There is the right mindset in going about it, and there is methodology. We tend to just focus on the creativity and lose sight of those other two. And so I want to bring those two to the forefront. There are a number of different design methodologies out there. IDEO is a very famous one. My alma mater, the Institute of Design, there was a process that a 7-step methodology. When I worked with Zayna at the SE Futures team, we had a 4-step methodology. They all have a similar feel in that it is, you are taking a complex problem and you are methodically addressing it, as opposed to waiting for the whims of creativity to try to navigate it. So it is repeatable. Inherent in this is there are the methods, individual methods. There are in the hundreds, and most of them are stolen from other fields and repurposed and brought together in unique ways. So from social sciences, from traditional art and design, from architecture, from engineering, and brought together in a new way. This talk is all about service design, but it is really not that different from some of the other design that's gotten some coverage in the media lately. Design is now, this is being also called design thinking, service design, human-centered design, experience-based design, design strategy, industrial design. They all have similar flavors, and they're being adopted really, it's become quite popularized in mainstream business media because it is recognized as a methodical way to tackle problems in ways that traditional management and traditional business thinking has not allowed before. So it's become, adopted by everyone from Apple through, through every Silicon Valley company, and now is making its way into healthcare. And I'll give you a couple examples of where we've seen this before. Probably one of the most famous is a case where I think I can't remember if it was Cincinnati Children's Hospital or it was in California. There was a recognition that 80% of children who are going to go go scanning MRIs had to be sedated. That was troubling for the lead engineer at GE. And so he underwent a design process to see, well, is there anything we can do to reduce the anxiety and stress that is causing children to need these sedative procedures? So they designed a whole new experience around the entry, the journey, the sensorial experience of what a child goes through in undergoing a scan. And they got the sedative sedations down from 80% to 10%. Now this is a really involved, fancy, high-tech example, but they're not all like that. Here's a simple one from our friends at Kaiser Permanente, where they were experiencing med errors, and they said, well, can we take a design approach? And what they found out by studying the experience of nurses, that while doing med reconciliations, physicians were coming up and talking to them, and they had to listen, but try at the same time to pay attention to what they were, the medication they were trying to reconcile. And that was leading to errors. So what they came up with was, well, a system to prevent that disruption and distraction for the nurses. And they created a sash, literally a piece of fabric that went around the nurses' shoulders and said, don't bug me, I'm focusing and it's important. And med errors went down. So I can't really give you take you through all of design, all of service design, or all of human-centered design, but I'm going to highlight 3 important parts. If you're going to learn anything about design, it's these 3 parts that I think are the most shocking, most interesting, most important things that you can also bring into your practices. Starting with empathy, problem framing, and building to learn. Many people will tell you the goal of innovation, or that sweet spot of innovation, is getting to the place where your solution is viable for business, is technologically feasible, and is desirable for humans. This is known as the balanced breakthrough model. The design lens on this is our starting place for this needs to be with figuring out what is desirable for humans, what is the human experience, and using that as the entry point to then figuring out those other 2. I'm going to give you an example that I really, really love. And this is a great example of starting with humans, with people first. And this is about an agency. I think they're all over North America, but I believe they started in Ottawa, and they were struggling with the homeless population, trying to give access to them to primary care and medical checkups. And they tried a number of different interventions, and everything they knew that applied to people who was familiar to them wouldn't work. This population was not visiting free clinics. They were incenting different things, and they couldn't figure it out. They partnered with another organization, and they figured out a new way to serve this population by looking at what was important to them. I'd ask you if any guess, but I know you guys can't respond. But looking at what's important to those people, it's right there in their screen. It's their pets. They offered free veterinary care if you showed up to the clinic. Someone who may not be experiencing homelessness or not be in that shoes may not have thought of that. That doesn't apply to their world. It's not rational for them. It's not something that you would think of, but they weren't in their shoes. But in putting themselves in thinking and experiencing and looking at through the lens of the homeless person, they realize what's important, and we'll be able to design an intervention that got people to the clinics, that got people living in the street to get checked up because it appealed to things that are important to them. Inherent in this is the idea of taking perspective. We think about the things that are important to us from our narrow lenses, and we think, oh, look how beautiful this intervention is, how great this idea is, or our frame on the problem. But we realize that people have different experiences and see things differently. You know, for me, I'm a white guy, middle class, relatively healthy, but I'm trying to tackle, and I've been trying to tackle things like the experience of aging, First Nations, Inuit, Métis, chronic disease, addictions, mental health, poverty, and homelessness. I don't experience any of those things. So in order to make any sort of meaningful dent in there, to work in any sort of meaningful way, I have to really check my perspective. And that means really being deliberate about starting with empathy. And I say this, empathy means is not just walking a mile in someone's shoes. It's not just a platitude. It's being deliberate at having to have humility to know I don't know very much. It's not my perspective. At the same time, having the curiosity, say, okay, it's not about my perspective. What is someone else's perspective? And looking for that. To get these perspectives, to get the understanding, to develop the sense of empathy, you have to look outside of there, and it's not often in the places we are comfortable looking. Like there are great research studies that exist. There is great research literature, but oftentimes, and I would strongly suggest that to be motivated to really develop that sense of empathy, we need to go beyond just our traditional secondary research methodology. We need to actually go talk to people, get their stories, observe what happens, go out and see it. In some cases, even try it ourselves. There are a number of great examples where technologies such as glasses that reduce your visibility, your vision, and so you can test what it's like to try to read a medication bottle with as if you were someone with glaucoma or with cataracts, and say, well, this is what an older person who has reduced vision, this is what their experience is like. Now, this stands in sharp contrast to the dominant methodology for collecting research in healthcare, surveying and quantitative studies. And you say, well, a lot of this isn't statistically significant. These methods aren't statistically significant. You have low N values. And there is some merit to that, but the purpose of this sort of study isn't to prove, it is to build empathy and insight. It's very different sort of data you collect when you collect stories about someone saying, for example, suicide. You can, through survey or traditional quant studies, figure out what is the suicide rate amongst homeless, or what is the percentage of homeless that are frequent users of the emergency department. That's very different than the story here about someone who is thrown themselves at the mercy of the emergency room and had to been ingloriously kicked back out to the streets only to contemplate suicide and throwing themselves into traffic. That's a very different type of data. One gives you a sense of size and scale, which is important. The other builds a sense of, wow, impact in you and motivation to try and to look at it deeper and to really feel what someone else is feeling. The second aspect of service design I want to highlight is the aspect of problem framing or reframing. To do this, I want to do a quick exercise. If you guys have a piece of paper around you, any sort of drawing utensil, or even want to do it on your computer, that's fine. Grab pen and paper, and I'm going to give you a few seconds to do a little exercise. I want you to design a vase. Now, I want you to design a way to enjoy flowers. I'll show you, many of you in many past iterations of this exercise, people drew more elaborate vases. Many people drew different ways of engaging with those vases. But then some people came up with great ideas like this. Monthly subscription to flowers. A app that allows you to identify flowers. A product that allows you to preserve your flowers. In changing the framing of the problem, we opened up possibilities. And that's really, really important when we think about the types of tasks and problems we're sent out to solve. When you change and reframe the problem, you create new opportunities to create new solutions, new ideas. And that is vital for when we think about the challenges that we are often set out, asked for, or we think are presented to us at the beginning of a design task. One of the literary devices we use to help us with this reframing is a process called, or a statement called, how might we? It's 3 very carefully chosen words. How, it's action focused. Might, it presupposes our ability to act. We might be able to do something, we might not, but there is still the opportunity to try. And we, it is a team-based approach. It's not, again, reinforcing it's not the lone genius. A great example of how this is applied was at Disney. Traditional theme park approach to rides. What is the best way to have people wait for the ride? And there is the challenge is wait for the ride. But we, in reframing that, how might we get people on the ride when it's their turn? Well, that means people don't necessarily have to be waiting, and that's what Disney did. They launched an appointment-based system, which freed people up for not waiting in line, which freed them up to be spending more money in concession stands, which just seems to be a win-win for Disney and its guests. This sort of thinking about reframing or spending more time on the problem isn't a design thing, or just particularly a design thing. Actually, I think it belongs very nicely in the realm of health and science. An unnamed Yale professor once said something to the effect of, if I had 1 hour to solve a problem, I would spend 2/3 of that hour in attempting to define what problem it is. And that's really, really important. Again, we tend to rush forward with a sense of creativity to solve the problem and not stepping back and saying, what problem is there? And in changing that framing, creating new opportunities. So often get asked something to the effect of, can we improve the patient experience? Can we improve our client experience? How can we? And this often comes with the baggage of how we are delivering care. We think about this frame from the point of care. How are we delivering care? How can we improve that experience? How we deliver care. And we have to shift that, and we can reframe it to how care is experienced. And in shifting that frame, we say, all of these new opportunities to start helping, all of these new areas that are in part of that end user of the patient or client's experience. Addressing the fact that they don't have anyone to ask, their concerns about finance, caregiver burnout, navigating a health system, healthcare transitions, adapting to changing physical abilities. These lists could go on for miles if we were to continue to pull out all the different reframes we've had, or different experiences that aren't just at that point of care. One of my favorites in my personal experience was when I was working with St. Elizabeth, where I was asked to look at, well, how can we improve our core home care experience? Implicit in that was how can we improve the interaction between our personal support workers and our clients? In going out and studying what that client's experience actually was, we discovered that really the real need wasn't necessarily about that interaction or improving that interaction. Rather, what was important to them was the interaction between family caregivers and the client and supporting that. And as a result, we were able to launch a new brand, a new product, a new service that cared for family caregivers and helped them care for their loved ones. The third thing I want to talk to you about, the third element of service design I think is really important, is this idea of building to learn. We are bad at thinking of new ideas and creating solutions that work. We are just, frankly, humans are bad at that for a number of reasons. The first is we're really poor communicators. When we think of new ideas that don't exist, we struggle to relate it to other people because it doesn't exist. We're really bad at envisioning a future that's different than what we have now. We are overconfident in our ideas and how effective they will be. And our cognitive capacity limits our ability to think through the implications of an idea. We may think, oh, that's a great idea, but we don't think it through all that well. This causes us to struggle with the idea of risk and new ideas. Is this something we should be spending our resources on? Should we be building this thing? We don't know. And we hold back from trying new things. There is a great solution to this, which is prototyping, making new ideas real, and in doing so, learning. Prototyping comes in a number of different forms. It is process, modeling what a service looks like. It is building a thing. It is road mapping an experience. It's anything that in a very quick, low fidelity way tests out, makes real a new thing and allows you to try it out. In doing so, it allows you to work things out as you build it, because as you make things real, you realize, oh, there are other questions you didn't address, you didn't answer. It allows you to iterate as you make these new things. So this is the famous OXO good grips. And the first iteration was that on the left-hand side, and they continued to make it, change it, iterate, and build again, and which allowed them to finally get to that famous design on the right-hand side. It allows us to learn from users. And I'll give you a perfect example of this. Again, going back to the Liz caregiver example, we launched a new service for different organizations to support caregivers within that organization. And this was what we called the caregiver zone. And it was a series of resources, videos, planning, coaching, supporting for the caregivers of family members of that organization. In this case, it was Veterans Affairs Canada. But before we built it, we created paper versions of the interactions, and we took it to family members of Veterans Affairs. And these were family members of people who were experiencing post-traumatic stress disorder. And we were very confident in our design. We had tested it out internally. We brought it to other caregivers, and then we brought it to this family, and we were floored by what we heard. And inherent to this was a certain registration process and whole user flow. And one of them said, I'm not going to register for this because I have to sneak into my closet at 2 a.m. in the morning when I need to get help. And this won't meet my needs. She shared a whole other side of an experience that we would not have thought of if we use our lens or the lens of that's what's familiar to us, or the people who we knew. We had to put this into the hands of people who are experiencing PTSD as caregivers. And it forced us to totally change the design. The great thing was, all we had invested in were a bunch of PowerPoint slides and didn't build anything. That was enough for us to get that feedback and get the experience from someone who is different than us to learn. We were able to then totally redesign it, and without, as I said, much effort or resources behind it. So that gives you kind of a very brief snapshot of 3 important aspects of design or service design, starting with empathy, reframing the problem, and building to learn. So we'd like to take the last little bit of this workshop, this webinar, to actually try some of this. Jay, should I pass you back over to you first, or should I just jump right into it?
Yeah, let's just kind of take stock of where we're at, and we'll shift our timelines a little bit. There were, a couple important comments that came in through the chat, centered around this questioning of the concept of empathy. So, of course, it's historically and continues to be central to design. But now thinking more broadly, Karen has made the point that, it's not just about empathizing, but is also about actually bringing people on board from underrepresented groups or from structurally marginalized communities who have historically been excluded from design processes. So, and compensating those people appropriately. So there's been some discussion around that, which I think was important for, given what we've described in the past hour so far. But, I think this has really come together really nicely. I'll continue to sort of monitor the chat, and we'll see what comes up for our conclusions at the end. Then in terms of our breakout, Paolo and team, so we're shortly after 1 o'clock, so we'll shorten down the time frame of the breakout. I think by the time we all get into our breakout rooms, we'll probably be down to about 15 minutes, taking us up to 1:20. Then we can come back for a 5-minute debrief and pass it over to Alex for final conclusions. So we'll be a bit quicker, but I think it's great for us to get over to the Jamboard, into the breakout rooms, and let's try this out. So back to you, Paolo.
All right. So as Alex introduced earlier on, I think, or Alex or Jay introduced, we're going to be using a tool called Jamboard. This is going to allow everybody on this webinar to participate. That's our hope, is we are going to all participate in some design activities. And so I'm going to introduce you quickly here through what this looks like. Can everyone see my screen? All good? Okay. So everybody's going to come in and be put into breakout rooms, and you're going to read over a very small bio and story of our user, Sabrina. And then you're each being put into a breakout group 1 through 12. You will then go to your breakout page, going through the Jamboard, finding your way, navigating to the right page. And at the top of that page is a scenario. Read through this scenario, and that should take just a couple minutes. And then as a group, with everybody participating, you're going to start to generate pain points, which are challenges that Sabrina might be experiencing in this scenario, or issues she might be feeling, negative experiences, things that might get in her way, things that might cause confusion. And you're going to create an individual sticky note for each one of those pain points, and do that on a yellow sticky note. Now, as you're doing this, make sure to have a conversation. This isn't an individual activity. So you're all talking about this, and make sure one sticky note for that pain point gets represented. You're going to have about 5 or 6 minutes to do this. Then, as a group, pick 3 of those pain points you think are going to be most interesting. And I want you to create 3 different "how might we" statements for each of those problems, each of those new pain points. So if and you're going to do that on blue sticky notes so we can visually distinguish. So an example would be, a pain point might be, there's confusion over what is happening. Our "how might we" statements, 3 different ones are, How might we help Sabrina understand what is going on? How might we help Sabrina keep updated with what is going on? How might we make it easier for Sabrina to ask questions? Each time we reframe that, that creates new opportunity. At the end of this, we're going to collect all of them, and we're going to see where we're at as a whole group. Each of us will have floating facilitators go between each of the rooms to make sure to help answer any questions, help you guys stay focused, and we'll be sending out messages around timing to make sure that you've moved on through the exercise.
Paolo, can you quickly just show us how to do a sticky note?
Thank you. Good call. On the left-hand side, you will see this little icon, sticky note. As you click on it, it will sticky note will pop up. I hit save, and that pops up.
One other point. So, I mean, I think people probably have had something at 1 o'clock. So we've had a bunch of people drop off. What we'll do now is, Paolo, when you're finished, we'll get everyone distributed into 12 groups. And then I'll go in and we'll just get rid of one group, but there's some nuance to that. So we'll send people from, for example, group 3 into groups 1 and 2. I'll go in and do that. So let's get everyone in the groups, and then we'll make sure that there's not only 2 people in a group. So back to you, Paolo, if there are other things.
I think we're ready to go.
Okay, let's do it.